First lecture will be by Dr. Lalith Wijayaratne, Senior Consultant Rheumatologist. So, sir doesn't need introduction. So, we are waiting for this lecture throughout the year. This may be the most important lecture of the year. So, over to you, sir.
Thank you very much, Monica, for that lovely introduction. You have made me very nervous. I don't think there's a most important lectures. Well, I would say one of the important lectures. Anyway, thank you very much, and I am extremely happy and delighted to address you today. And my role today is to give you a very basic understanding on medical rehabilitation. All what I'm trying to do is to tell you what rehabilitation is all about. So that's my role today. So this is my topic. And to enable, can all of you hear me, please? Am I
Yes,
okay?
sir.
Yes.
Yes.
For me to sort of deliver this lecture in a better way to make you understand, these are outline which I have intended to follow today. Right. So my topic is on medical rehabilitation. And first and foremost, before I go any further, we have to have a very precise and a very clear understanding as to what we mean by rehabilitation. If I go stepwise, if you look at any dictionary, I looked at this term in the Oxford English Dictionary. The Oxford English Dictionary sort of defines, or the meaning given in that is that rehabilitation is a process to help someone to have a normal, useful life after they have been sick or after they have been injured or ill. Now, if you look at this very simple definition or meaning given in one of the leading dictionaries, there's a term which needs further clarification. We had to ask ourselves, what does it mean by a normal, useful life? So, can I ask you, unfortunately, this is a virtual meeting, so I can't ask questions and bully you, but I'll give you a minute to formulate your thoughts. In your mind, with your experience with the world, your experience as doctors, what do you mean by a useful life? What are the components of the use of a useful life? Well, I'm said I had to give the answer myself. When one talks about a normal, useful life, there are three main components. The first component is for a person to have a useful life, he or she should be devoid of illnesses. Either there should not be any illnesses, or if there is a chronic illness like a non-communicable disease, that should be under control. You're all aware as doctors that we have many organs in our body, and each and every organ is susceptible to various types of injuries and illnesses. So the first component of a normal useful life is all these organs should be functioning normally, or if there's any disease, they should be kept under control so that they have a reasonable function. The second component is being healthy. Your second requirement is that you should be able to attend to your own needs. That is, when you wake up in the morning, you should be able to get up from bed, go to the washroom and wash yourself, to toilet yourself, to feed, and to move about, and also dress yourself. So this is the second requirement for you to say that you have a normal, useful life. Doing your work alone itself is not enough. To be or to have a normal, useful life, you should have the capacity or the ability to interact with the community. We know that we can't live alone. For us to have a normal, useful life, we should interact with the community, which means that we should have the capacity, we should have the ability to interact with our family members, our relations, neighbors, friends. We should be able to make use of the community services like religious places, supermarkets, post offices, and other offices. And also, we have a give and take phenomena. We all should be able to give something to the community in the form of a job or social work. So these are the main three components that one requires to call that he or she has a useful life. And in rehabilitation, these are the three components that we like to address when we care for our patients who need our help. Now, So this is the definition given in the Oxford Dictionary, but if you go a little bit further, we are medical personnel caring for deceased and injured people. And if you look at the same term defined in a medical textbook, it goes a little bit further. If you look at any standard medical textbook, medical rehabilitation or rehabilitation defined as a process which tries to improve the capacity of a person so that he is able to function at the highest possible level. So here it is a treatment process. And here what to try to sort of, the main client is a person who has got a physical or a mental problem or an illness or an injury. And the main goal in medical rehabilitation is to achieve the highest possible level of function. So again, in this definition, the term comes up, which needs further clarification, because according to the medical definition of rehabilitation, the main goal we are trying to achieve is to get at the highest possible functional level. So we have to ask ourselves, what do you mean by the functional level? Well, if you look at it in simple terms, it is as same as the three components which I defined under a normal useful life. So therefore, in medical rehabilitation or in rehabilitation in the health sector, there are three main areas we try to address. At the level of the organ, the ability to attend to our own needs, and to interact with the community. In fact, the term rehabilitation, I can remember me as a student, as a postgraduate, and even as a young consultant, was very bizarre. It was very gray. Different countries, different continents were using various definitions. Fortunately, to make matters more sort of simple, in 2011, that is about 10 years back, the WHO, they put up a very comprehensive, detailed document, which they called as the International Classification of Functioning, Disability and Health, which takes the human function, or which defines the human function the exact way which I have done at the moment. Right, so this is the document that everyone who is involved in caring or treating or rehabilitating people with disabilities, they use this document, which we call as a Bible for rehabilitation. And this document clearly defines, it goes into great detail, it goes to town on the human function. So so from here onwards, my lecture will be based on this ICF classification, which came up in 2001. And if I take the important sort of concepts or extracts of that, which is important for this lecture, this document classifies the level of function under the same three headings: at the level of health, for illness or a pathology, at the level on your ability to attend to your own needs, and your ability to interact with the community. So, according to this ICF classification, you have the first level called the body function and structure. The ability for you to attend to your own needs is called as activity, and your ability or inability to interact with the community is defined as participation. Let me take this into a little bit more great detail. So this ICF classification looks at the human function under three main levels. The first level is the body function. Now, what does that mean? If I put it in a different way, our human body consists of many organs. Each and every organ has got a different function. That's what we do in clinical medicine. We assess, we take a history, we examine, we do investigations when we assess the function of each and every organ. So at that level, what we do is the practice which we have been adopting over the last so many years. We look at the function of each and every organ. So that's our first level. So we put all these organs together, and that brings up the human being. And then the human being as one piece or one person has to do certain activities by him or by herself, no matter what religion, what race, what profession he is on. This person has to carry out certain activities by himself. and that is called as activities. And these are the activities which we usually name as activities of daily living or the self-care activities. It doesn't stop there. As I told you earlier, we have a third level. Third level is our ability to interact, to participate at the community level. So those are the three levels that the ICF classification talks at, the three levels of functioning when we have to talk about medical rehabilitation. So those are the three levels. So you know that in normal people, all these three will be fairly reasonably normal. But what happens is that life is not so rosy. People are subjected to various types of illnesses, diseases, and injury. And when one of these health hazards do take place, your function can get disturbed at one or two or at all three different levels. Right, so what happens is when an injury or illness affects the function at these three different levels, and when the function gets disturbed, according to the ICF, they are given specific names. If the illness or injury affects the function of an individual organ, that is called as an impairment. That's what we are used to. Most of us are involved in the field of rheumatology. And here we talk about the function of the musculoskeletal system. The pulmonologists are involved with the function of the respiratory system. Similarly, its impairment is where you get a pathology or an injury or a structural abnormality at the organ level. If the injury is serious enough to get into the second level, where the injury or the illness sort of disturbs the day-to-day functions or activities, in such a situation, we define a term called activity limitation. We say that this particular illness or the injury has resulted in these activity limitations. Sometimes the injury can be very grave or very serious, where it affects your third level, your ability to interact with the community. And once that level is affected and your ability to interact the community is disturbed, that is called as a participation restriction. So therefore, all over the world, where personnel are involved in medical rehabilitation or caring or the disabled, these three terms are used all over the world, and they have become standard terms today. So having understood the basic terminology in rehabilitation, I think the next word I have defined is disability, because whenever the term medical rehabilitation comes in, the word disability also comes in there, because the word rehabilitation is implemented. The rehabilitation program needs to be given to people with disabilities. So what do you mean by a disabled person or a disability? According to the ICF classification, if an injury or an illness affects either one or two or all three levels, such a person is called as a disabled person, or such a state is called a disability. So remember, even if you have a person who has got a pathology in an organ without affecting the activity or the participation, according to the ICF, such a state is also has to be defined as a disability. Right. So therefore, the ICF classification clearly defines what the human function is, and the human function is then sort of defined in three different levels. Now, if you look at this human function, particularly when it gets disturbed either by an injury or an illness, there are other non-illness factors, or there are other factors other than this injury or the illness, which can either help it or further disturb this function. And these are called as contextual factors. Here, what I mean is, say you sustain an injury, you become a paraplegic, and all your functional levels are disturbed at all three levels, but there are other factors in the environment or personal factors which can further make this function worse, or it can help to improve the function. So let me go into some details about the contextual factors. What are the contextual factors or non-health factors which can affect the function at these three levels? let's look at the environmental factors. There are two main environmental factors which can affect the three main levels of functions. Those are physical barriers and social barriers. Let me go into more detail about that. What are the physical barriers which can affect the human function of a disabled person? Well, this is what the physical barriers of two types: geographical barriers and architectural barriers. Sometimes, particularly if you look at our rural or village sector, if you look at the geography or how their houses are placed, there are many villagers who live in dwellings like this, where the access to the main road or the main city is not so well defined. There are either footpaths or there are paths like this. And if there is a wheelchair-bound person or a paraplegic person, they will not be able to come out of the house and interact with the community. So there are geographical barriers which can affect your human function. There's another geographical barrier, a temporary structure which they have laid to cross this small stream of water. Again, a wheelchair user will not be able to cross this and either enter his house or from his house to the community. So there's another geographical barrier. This is what you call as an architectural barrier. There are many buildings in the city, hotels, government buildings, which with steps like this. And if you are a person who is on a wheelchair, this architectural barrier will prevent him, will block his access to the services, and that will be another problem for to sort of be independent in the community. Then the other main factor which the environment brings on for the function is what you call as a social barrier, stigma. I don't think I need to go into great deal of this. I think all of you know, particularly who have done the appointments in Ragama, you hear many stories as to how we have rehabilitated our disabled people and sent them home. But there are so many social stigma which sort of prevent them getting into the community. There are many places which do not offer jobs for people who are on wheelchairs. There are in the social, I know, if I recall my thoughts about the spinal cord injury patients, there were many young men who could not get married because they were wheelchair born. They couldn't get good jobs. They couldn't associate or they could enter the streamline of getting good jobs and good opportunities just because they were disabled. So the community refuses them. This little cartoon which I got from a book, which I thought sort of describes very well about the social barriers. And this guy who is on the wheelchair says, I'm not disabled or differently able or specially able. I am an accountant in a wheelchair. Absolutely true. I mean, just because in a wheelchair does not necessarily mean that his work capacity or his IQ has gone down. There's another cartoon which I got, the stigma, which again, which clearly sort of, the cartoon very clearly explains the physical and the social barriers which prevents or which hinders a disabled person entering the community and behave or be like any other person like you and me. So there are a lot of environmental factors which will affect the function at the second and the third level. And of course, there are a lot of personal factors, as doctors we know. The motivation, I think all who are involved in rehabilitation know motivation, one of the strong factors. There are some patients who have given up. They say they don't want to do the exercises. They don't carry out our commands. They have given up. Then our rehabilitation process completely collapses. The motivation is important. Age, very well understood. Gender, social background, again, your resources you have, and also other comorbidities. If you have a patient who is a paraplegic who also is having heart failure, asthma, renal problems, again, they'll be weak. They won't be physically and mentally strong enough to go through the rehabilitation process. And these comorbidities can further make their activities disturbed. So there are a lot of other factors which can sort of disturb your function. So therefore, if you look at this schematic, which has been defined with the ICF, I see it as a very useful schematic because it explains as to how a health condition, an illness, a disease or injury can affect the body organs, and how that can in turn affect our activities, our daily living, and our ability to participate in the community. And it also, the ICF, the other very important factor is that it also explains as to how the other non-health factors can influence the activities at all these three levels. Now, in medical rehabilitation, another word we start to use is quality of life. Quality of life is purely judged on the second and third levels of activity, right? You have to always remember that. The term we use in medical rehabilitation our main focus is not mainly on the pathology. Those who are involved in rehabilitation will agree with me. When you are doing our rehab ward rounds, when you are doing our MDT discussions, we hardly talk about the pathology or the diagnosis. Our main focus is on activity and participation, which is also are the two main determinants of quality of life. Right. So now what I thought was, having understood what rehabilitation is and having understood what the functional levels which has been defined by the ICF, let us try to sort of understand how are we going to apply this knowledge in our day-to-day practice with people with disabilities. In order to do that, I thought of taking this simple example. We'll take this hypothetical example. Say we have a 65-year-old lady in front of us who has had rheumatoid arthritis for a long time, and as a result, she has got secondary OA of her right knee, and therefore her mobility is disturbed. The physiotherapists have rehabilitated her to a certain extent, and she's fairly independent in mobility using a pair of crutches. Her pain is fairly under control because we have analgesics, and the use of disease-modifying drugs have controlled the rheumatoid arthritis states. At the moment, she is on physiotherapy. But if you look at her social status or the social history, she lives in a house which is in the fourth floor of a multi-story building, and she has certain tasks to perform as a grandmother. As usual, she has to take her grandchildren to school, and her husband is involved in a small business, and she has to give some help to the husband as well. Now, this is information we take from our history, and our next sort of role is to fit in with the schematic. So ideally speaking, if you want to do a good job of work in medical rehabilitation, I personally feel that that's what I do. If you just feed all this information to this schematic, rehab becomes very easy for us. So if I just extract the information which I gave you just now about the 65-year-old lady and sort of fit into this format, this is how it looked like. Here we have illness, rheumatoid arthritis and secondary or the knees. And that has caused certain pathology and clinical features. The pathology is that there's ongoing inflammation from rheumatoid arthritis. And of course, the osteoarthritis of the knee has affected the patient's the joint, all the structures, and there are structural damage. As a result, these activities are limited, and also certain participations or work in the community are restricted. Then we had the contextual factors in the environment. Sadly, she's in a fourth floor house, and she is using crutches, which will make mobility a bit difficult. But the positive factors are thanks to the physiotherapy and the rehabilitation she has undergone so far. She is somewhat mobile with a pair of crutches, which she can move about in flat ground. She's on physiotherapy, our goal is to improve her mobility further. And the analgesics have made her pain-free, which she can attend to her activities with minimal or no pain. And of course, she's a sociable lady because she should be sociable to take her grandchildren to school and to help her husband. And we are lucky that she has, other than rheumatoid arthritis and osteoarthritis, she has no other comorbidities. She's a very motivated lady. So you can see, if we sort of fit in the little information we have in this schematic, we know where to address. So if you on this schematic, of course, we have to sort of continue our drug medication or drug therapy to make sure that the inflammation is kept to the barest minimum, to make sure that she is either in remission or minimum disease activity. Then, of course, there are something happening there. So the physiotherapist will have to work harder, and she'll have to do her home exercises to make sure to build up her muscle power and stability of the joints. And this is something where it's beyond our control, where we can look into to make life more easy for her. and the others are in blue, where nothing much needs to be done. So you can see as to how helpful it is to put the information to the schematic, and we know the areas which we need to focus a little bit more in the rehabilitation process. So if you look at this rehabilitation process, therefore, here we have a human being whose health condition or the injury disturbs his or her function at these three levels. And we should understand that this functional disturbance which occurs from the disease is not a static process, it's a dynamic process. Why do I call it dynamic? Because the pathology, the environmental factors, and the personal factors all will decide the level of function at all these three levels. So therefore, you have to understand that when we talk about function in medical rehabilitation, it is never static. Day to day, it can change depending on these three basic sort of influencing factors. Right. So having understood about the human function and about rehabilitation, let us try to bring this knowledge to our day-to-day practice. So therefore, all of us are involved in medical rehabilitation. How are we going to implement that? How we are going to implement is whenever we have a patient in front of us with a non-communicable disease or a musculoskeletal disease whom we think is going to affect the function all three levels, we have to take a detailed history. Right, so in our detailed history or detailed clinical evaluation at the end of it should cover function at all these three levels. So how am I going to do that? So to cover the first level of function, to assess whether your body organs are functioning normally and the structure is normal, that we have done over the last so many years from our third MBA days. We take a detailed history, we perform clinical examination, and we go ahead with the investigations. And after the good clinical evaluation and the investigations, we are able to say the level of the functioning and the structure of different organs. Then we have to go to the activities that should be done in the social history. So therefore, if there's a patient whom you think whose function is going to be disturbed, we have to spend a lot of time in the social history. We not only ask about the personal habits, about smoking, drinking, or the family status, we have to do a detailed assessment on activities of daily living. So that is a must in our social history. Then the social history should go a little bit beyond that to find out whether there are any environmental or personal factors which should affect it. Because I think if you look at this ICF classification, why I like it most is that when we were medical students and up to our MD level in medicine, we were only focusing on that. All what we learned, all what we were taught, all what we studied was as to how an injury or an illness affects each and every organ, what the clinical features are, and how we can put it back to normal. But thanks to ICF, now we can look a little bit beyond your human body. The ICF enables us to have a very clear, precise understanding as to how injury or illness affects not only the person's organs or the tissues, but beyond the person on his activities and participation. So therefore, as clinical carers, when we are assessing our patients, we should not only look at the organ or the system involved, we should look at the impact of that illness or that injury at both these levels. So we should go in great detail about the environmental factors and the personal factors which can have influence on the latter two clinical levels. Then, of course, the environmental factors, as I told you in the history, and we had the personal factors. All these things have to be sort of assessed in great detail when you are doing a clinical evaluation. Right, so having understood all that, my next role is to tell you about medical rehabilitation. Now, if you look at the definition which I gave you right at the beginning of my lecture, rehabilitation in any textbook is defined as a treatment package or as a management package which restores a person's physical and mental capabilities which has got damaged or disturbed due to a disease or injury. And the main goal we try to achieve in rehabilitation is to get the highest possible level of function. And the function has been defined by me already. Right. So therefore, In rehabilitation, our main goal is to look into the human function at all these three levels. And our main goal is to bring the function at all these three levels to the highest possible level. So therefore, rehabilitation, to implement a rehabilitation program, you have to assess the function at these three levels. Right, so how are I going to do that? So as I told you, first and foremost, the function of the human being is disturbed either by illness or injury. So therefore, health prevention and health education plays a very important role in medical rehabilitation, because prevention of disability is one of the important roles or one of the areas we have to cover as people involved in the sector. So medical education and health education comes there. Then when it comes to the body function and structure that we have been doing all this time, from the time we were interns, the doctors and the nurses collectively as a team, the doctors make a diagnosis and they sort of plan all the medical treatment. The nurses also come in and assist us to implement the management program. So that's done by the doctors and the nurses. Then, of course, we had to look at the impact of the injury or the disease on the person's function, the two defined levels. And that all what we can do to assess and find out what the deficiencies are. But to address it, we don't have the necessary skills or the knowledge. We have a different profession in the health sector. They are the physiotherapists and the occupational therapists. So the physiotherapists and the occupational therapists, their main role is to address the function which has got disturbed at the activity and the participation level. Then, of course, there are some patients with disabilities who have some environmental factors which can make it worse. And this has to be addressed. This is beyond our setup, our area. And to address that, we have the social worker. And if there are any personal factors, particularly I am focusing on motivation, because it's very obvious when people fall ill, when they are injured, they are traumatized, not only physically, but also mentally. And I'm sure if you come across people with road traffic accidents, strokes, where things happen during a fraction of a second, their mental state is very poor. So we need a lot of clinical psychological support to elevate their mood and to help them to come to terms with the problem they have faced with, to go ahead with our rehabilitation. So therefore, you can understand that our main focus in rehabilitation is at these two functional levels, which we call as a quality of life. And in order to do that, you need a team of people. We as medical personnel alone can't address these three levels when there are problems. So if rehabilitation is to improve a human being's function, which have got disturbed, and if our main focus needs to be at all these three levels, we as medical personnel can't do it alone. Of course, we can find out what the deficient areas are, but we need a team of people to implement the rehabilitation program in order to achieve the highest possible function at all these three levels which were defined. Therefore, when we talk of rehabilitation of the injured or the disabled, we have a team which we call as a rehabilitation team. I like this slide a lot because we have to understand that when we're implementing a rehabilitation program, it is a patient-centered program. Rehabilitation, I see, is very unique. It's very challenging. It's very interesting because it's a very patient-specific condition. If you look at the medical illnesses like pneumonias, myocardial infarction, hepatitis, meningitis, whatever you may call it, it's a pathology-centered management. You talk about the pathology and then you manage it. But here, you might have the same disability among two people. I'll give you an example, which I used to give when I was in the rehab sector. You have a CEO or a consultant in a specific field traveling normally with his driver, and his vehicle sort of goes down a precipice, and both sustain a spinal cord injury. Both have the same injury, both have the same disability. But the consultant who was in the car is very wealthy, he has all the backup, he has all the knowledge, he has all the help, but the poor driver is a breadwinner. He has no one to help him. So the rehabilitation process in these two people, although the pathology is the same, although the functional disturbance is the same, the approach, the way you look at it, the way you plan it, everything is different in these two people. So rehabilitation is unique in that sense that it is a patient-specific thing. Everything has to be planned. Your goals have to be set according to the patient's aspirations, according to the patient's other facilities and other resources the patients have. So these are rehab. So to implement a rehabilitation program successfully, in order to achieve our goals, we need this rehabilitation team. And they have to work as a team. Hello, am I okay? Am I too fast?
No, sir, it's okay.
Is that okay? Right, okay, fine. Are you sleeping or are you awake? I don't know.
Listening very well, sir.
I hope, thank you very much. Thank you for the honor. Anyway, right. So we are the rehabilitation. So let me look at the team. So now we as consultants or people involved in rehabilitation, we play a very important role. We are the coordinators. So therefore, no rehabilitation process will be successful unless we know the role of each and every different person, because we had to call them at the correct time to implement this program in a correct manner. So rehabilitation is not complete unless we know the role of each and every person. What is our role as doctors? Well, you know that we have been medical carers, that is very, very clear. But we are, when I say manager, I won't say that we are the important people, but it's like the manager of the team. We are responsible for what happens in the team. We are responsible for the patient. Everything we have to take the responsibility. Legally, we are responsible. That's what I meant by the manager. We have to coordinate with the team. We have to know which team member should come at the correct time and what team and which team member is needed to achieve our goals. And as I told you earlier, anything going wrong with the patient or the rehabilitation process, you are answerable. The legal process or the ministry or whoever it is or the patient, whatever it is, always you are answerable. So therefore, you have to know what exactly is happening with the patient and the treatment process. Then we have the nurses. The nurses' role, apart from what we know, in the disability sector, their main role is the care of the skin, bladder, and the bowel. So if there is a patient who is bedbound, the nurse has to, in the multidisciplinary team, the grand ward round, and in the other physical ward round, the nurse has to give us very detailed about the state of the skin care, if there's a pressure sore, all the details about the pressure sore, the size, the diameter, what has happened, what the treatment is on. Same with the bladder, if there's a catheter on, when was the catheter inserted, what is the size of the catheter, any complications, color of the urine output, all the details. Everything is under the nurse's care, and same with the bowel care. So that's very important. And about bowel care is very important because in rehabilitation, it's important that if we have a patient who is bedbound, who has not had a motion for 3 days, always when the nurse says the bowel is not open, you have to ask how many days. If it is the 3rd day or more, you have to intervene. You have to do a rectal examination and see if there's a fecal impaction. Almost always there's an organic basis if the bowels have not moved. So that's what I call as interdisciplinary care. So when the nurse gives that information, you have to intervene and do something about it. And also, you know that when it comes to the disability sector, if you look at our stroke patients, if you look at our patients after spinal cord injuries, many patients, I'm sad to say, go back home in a disabled state. They are not the same state as they were before the injury. They go in a wheelchair, or they have to go with an nasogastric tube or with a catheter, and they are going to an environment, their home setup, where none of the family members know anything about the NG tube. They know nothing about the catheter. So a lot of education has to go in before you discharge the patient. You have to teach the family members about the possible complications, the skin care. So all that has to be done by the nursing and the other staff. So the nurse, so when it comes to bladder, skin, and the bowel, the nurse is an educator for the family members and teach them what they have to look for. And the other thing is, if you look at the rehabilitation team, if you look at the doctors, the physios, the occupational therapists, they are with the patient only for a limited period of time. And if you look at all our hospitals, we have visiting hour in the noon and in the evening. During visiting hours, none of us are available in the ward other than the nurse. The nurse is the only person who's available in the ward. So we see the nurse as a very important coordinator between the patient's family or the patient's carer and the rehabilitation team. So if there's any information which needs to be given, either way, if the family members or the carer wants to know about the patient, the nurse has to coordinate the rehabilitation team and set up the meeting so that the carer or the relations can come and discuss with the rehabilitation team, and vice versa. The rehabilitation team needs to educate or give a message. It happens especially in spinal cord injuries and strokes, where we are talking about prognosis and aftercare. Again, is a nurse who coordinates the family members and arranges the team, where the family members or the carers can meet the team members and we can have a detailed discussion. So therefore the nurse too plays a very important role in the rehabilitation process. Then we have the physiotherapist. The main role of the physiotherapist is given in blue. They do a lot of things to relieve pain. And of course, whenever there's problem regarding balance, function of the joint, the muscle, and transfer. So these are the areas that the physiotherapists are involved. So if there's any patient, no matter what illnesses they are suffering from, if there is a patient who has got disturbance in any of these areas, you have to call a physiotherapist. It is a physiotherapist who has all the skills, necessary skills to address these issues in order to achieve our goal of getting the maximum possible achievable function. So that's the role of physiotherapists, and they have various techniques, exercises, machines, gadgets to implement with their skills to improve the functions. Gait training or walking training is another important role. And you know that physiotherapists use various assistive devices like frames, crutches, and yes, and wear devices. And this is again another specialized areas of the physiotherapist. And if you go to a physiotherapy department, you can learn and you can see how they use this to make people more independent in their mobility. The occupational therapist is the other member. He also plays a very important role, because if you look at our activities of daily living, everything is sort of done with our hands. Occupational therapist is also called as a hand therapist. The physiotherapist, all what the therapist can do is to get to the required balance, the muscle power, and the joint movement. But the nitty-gritty of holding things, maneuvering things, the nitty-gritty things of the skills of doing it is done by the occupational therapist. And he too uses a lot of devices in order to improve the hand function on the gross and the fine movements. There's another role by the occupational therapist, because as I told you, one of our main roles in rehab is to focus on the third level to make him independent to link or interact with the community. And there are some people who can get back to their jobs. So if there's a person with a disability whom we have sort of rehabilitated to a state where we think that he can continue his job, certain adaptations, certain changes needs to be done in his work environment. And also the patients are going back home in a wheelchair or on a stretcher or in a very disabled state. Certain structural changes need to be done at the house, because some houses are not architecturally, or some houses are not very well planned to look after a disabled person. So all this advice, the structural planning, the structural changes which needs to be done to keep this person who comes in a different state, either in the house or the workplace, all this planning and advice comes from an occupational therapist. These are little slides to show you. I'm sure if you go to any OT department, you can see all this happening. This is a patient with rheumatoid arthritis. You can see the deformities in the hands, and she is so deformed, she can't make a tight grip. And the occupational therapist has adapted or sort of, they have sort of changed these tools, the cutlery, so that even with a poor grip, now this person is trained to have his own meal. He has been independent. He has been made independent at the second level. Now she's independent to do his own self-care activities, such as feeding. A little slide to show you how OTs have done their work. This is another thing where the OT this person has got his shoulder is ankylosed because of rheumatoid arthritis. You can see deformities there, so he can't raise the arm. So what the OT has done is taken the comb, and he has designed this assistive device which he can plug, or which can sort of connect to the comb, and he's taught how to comb his hair. So he has been again made independent. At the second level, or self-care activity by the OTs by giving him this special device to plug it to his comb. This is another commode elevator. Again, people with hip and knee problems cannot sort of sit at a very low level. And these are OT who examines the patient's hip and the knee range of movement, and they can sort of design a commode elevator where the person can sit on the commode comfortably and attend to the toilet needs. So there are many aspects that you can do, and these are again what the OTs use, various equipment or assistive devices. This is a patient who has sustained a stroke, who had a right hand deformity and weakness, and again, it shows how the OTs can implement their skills and improve their writing function. Again, they have been independent at the second level or the self-care activities. Then we had the arthritis, because a lot of our patients, particularly who have musculoskeletal diseases like osteoarthritis, rheumatoid arthritis, who get knee injuries, sports injuries, who have wobbly knees and knee problems, they need various sort of devices like knee braces. All these can be designed, and that's the specialty of an orthotist. And of course, people with certain foot deformities and heel pain, there are various ways that orthotists have the necessary skills to design special shoes to make sure that he has a comfortable or a pain-free or a very active mobility. Then we had the social service officer, because a lot of people are being sort of, they lose their jobs, they can't get a proper income, so they have financial difficulties, which we as health personnel can't address much. So the social service officers are there to help us with looking into their financial needs, and those particularly who can't get back home. There are homes, disabled homes run by the social department, and that is also fulfilled by the social service officer. So therefore, you can understand that in order to implement a rehabilitation program, rehab is to bring the level of function at all that define three different levels. In order to address those three different levels and to bring them to the maximum possible function, we need a team of professionals, which I have defined already, and it's a multidisciplinary team which has to join hands, and it is the interdisciplinary approach which makes the rehabilitation process a success. So therefore, if someone asks me what is the main requirement or the requirement to make the rehab process, in my little experience, is nothing much but the coordination or the team spirit among the members who are in the program together. So if I give a little example, if you look at the plain and simple adhesive capsule of the frozen shoulder, the patient might come and say, doctor, you know, my shoulder is painful, it's stiff, I can't comb my hair, I can't shampoo my hair, I can't sort of reach the back, my reach pocket. So a lot of problems are there. So what happens is the shoulder range of movement is greatly restricted. So if there's no major bony abnormalities, we call the physiotherapist, who will give a lot of, will use his or her skills and try to improve the range of movement of the shoulder. That alone won't enough, because the patient doesn't come and tell me, doctor, my ROA, my range of movement is lost. Patient comes and says, I need to comb my hair, I have to shampoo my hair. That's what the patient needs. So there's a functional element. So the occupational therapist comes in and there's a nitty-gritty. So you can see from this little example, the importance of coordination, sharing your knowledge, sharing the defects you have seen the patient among them. If the physio and the OT does not coordinate very well, your whole process becomes a failure. So this is a little example to show you how important it is for these people to talk to each other, share their knowledge, and try to work together to achieve a common goal of improving the function at different levels. So how is it implemented? I told you, you need a structured approach. You have to have an interdisciplinary team. So the team has to be there. And today we are very lucky that the academic colleges from the developed world have brought in various indices. So all this quality, ability to comb the hair, ability to eat, all these are qualitative. All these are qualitative things. If you look at the function at the second and the third level, interact with the community and the self-care, all these are qualitative terms. Can you comb your hair? Can you brush your teeth? Can you write? Can you use a computer? Can you text? Can you dial a number? Can you drive a car? All these are qualitative things. But thanks to the academic colleges in the West, all these have been now translated to numbers. But it's very easy to work with a number. It is very easy to treat hypercholesterolemia, diabetes, and hypertension, because we're looking at numbers and treating. A patient comes and says, "Doctor, I can't walk, I can't write, I can't type, I can't text." Now, in order, if you are following up that patient in rehab, it's very difficult. If the patient says, "I'm a bit better, I'm a little better," well, more or less better. Those are terms they use. So then we can't sort of understand what they mean. One patient might say, "I'm a little better. Doctor, more or less, I am okay. Well, not bad." So all these are very descriptive terms. So thanks to the colleges, we have these indices coming, which has been introduced. And now in rehab, we work with numbers. Numbers have enabled us to achieve our targets. It has made rehab very easy. So we have set goals. I'm sure when you do your rehabilitation MDT ward runs, you might have seen, we always have a set goal. Each and every member has a set goal. We work around a goal, exactly the way we do in medicine. If you are diabetic, we have a goal to bring down the fasting blood sugar to 120 or HbA1c to 6.5. Same with cholesterol. If you are treating a patient with dyslipidemia, our goal is to bring the total cholesterol to 200 or LDL to 100. Here too, we need to have a goal when we are implementing rehab program to our disabled people. So it's a goal-oriented program, and we have to have frequent multidisciplinary team where all the team members sit together under the same roof, and each one keep on giving the information he has gathered or what his plans are. And by pooling the information and have a collective decisions is the thing which makes this a success. And of course, there are a lot of things beyond us. So rehabilitation, as I told you, involves other sectors. So it's not only health, social services, all these have to come in if we were to think of the third level of to improve the function at the third level. What determines the success? As I told you earlier, it is, of course, there are patient factors and the health or the rehabilitation factors. In the patient factors, of course, you should be motivated. If the patient is very depressed, refuses to carry out our demand, refuses to carry out whatever advice we give them, and if they're always sort of in a very gloomy mood, our rehab is not successful. Cognition, everything is through commands. There should be a lot of information going to and forth. So they should be able to understand what's happening. All these things are, and the comorbidities, all these will decide the final outcome of rehabilitation. Then from our side, the team is extremely important. I have no words to re-emphasize the importance of it, and it is an approach which makes it a success. Lastly, I have 5 minutes more to go. Are there any challenges? Yes, there are many challenges to implement this. As you know, the elderly population is ever expanding. Now, I am also, as you know, I also belong to the elderly category. And so all the elderly people, there are so many comorbidities, and elderly people are the people who are prone to get all disabilities. So it's expanding. So it's a huge burden which we are going to face in the future. As you know, I need not go into that. Non-communicable diseases are increasing in numbers. So we are getting more and more patients suffering from strokes, myocardial infarctions, diabetes, uncontrollable diabetes, amputations, peripheral vascular disease. A lot of things are happening. And sadly, if you look at our past, we had our extended family, the granny, the grandchildren, all the way in the same house or all in the same compound. So if there was a disabled person in the house, there are a lot of people to come and give a helping hand. But sadly, now we are reaching a state where we have a nuclear family. That is, it's only the family is in that house. Health is a very, very difficult commodity. So all these are challenges we see when we sort of see a disabled person in front of us, and when we have to sort of the rehab program. So according to the scheme, I have come to my end. And lastly, I'm sure a lot of you must be asking, especially those who are in the rheumatology field, maybe ask me, why is this all this fuss? Because rheumatology, there are so many things coming up. There are a lot of things in connective tissue diseases, rheumatoid arthritis, in vasculitis, become extremely interesting. It's very, very dynamic. It's very moving. What is this nonsense? Why is it that we have to know something about rehabilitation? Haven't you got to know something about autoimmune diseases, vasculitis, and all these other diseases? Well, the answer is no, because you are responsible, because we as a rheumatological population, we are involved in musculoskeletal diseases, and whatever it may be a autoimmune disease, it may be a degenerative disease, whatever it may be, most of these musculoskeletal diseases end up in disability. So we are responsible. And we have a huge role to minimize this disability. And I don't think we can implement a good rehabilitation or we can refer them to the rehabilitation sector unless we have a clear understanding on what's happening there. So therefore, I feel that even as a concerned rheumatologist, even the specialty of rehab is coming up very fast. I'm happy to hear that. But even then, if it evolves to a very high level, still as rheumatologists, we have a great role to play in the process of medical rehabilitation, particularly when it comes to musculoskeletal diseases. So may I summarize? I have 2 minutes more to go. We have summarized that rehabilitation is a team concept. It should be mainly patient focused because from patient to patient, your rehabilitation goals, plans, everything differ. It needs a very positive approach. And you have to start bringing not only the team, the family members, and all the stakeholders who are involved in the process. And remember here, unlike in medical illnesses, like infarction, where the patient is a passive recipient, in rehabilitation, it's always remember he's an active participant. As you can remember my slide, he is the most important member of the rehabilitation team. He has to tell us what he needs and what his deficiencies are. So therefore, in rehabilitation, the patient is an active participant. And all we're trying to do in rehabilitation is to improve the quality of life. And today there's ample evidence to prove that by simply improving the quality of life, you improve the survival. Their lifespan is also improved. So by giving them a good quality, we also improve the quantity. They live longer and they'll be happy. So with that, I think I have come towards the end of my lecture. So thank you very much for your patience and listening to me. I'm so sorry, I can't see your faces, whether you are yawning or whether you are sleeping. I hope that I was able to give you a very basic understanding on rehabilitation. I think we have another 2 minutes more to go. It's 12:28. Monica, anything?
Yes. Are there any questions from audience? So if you have questions, there's time, 2 minutes to ask your questions. Kalhari, are there any questions?
No, they are quite okay. I think they are
Okay.
they are saturated.
Okay.
I think they have to be rehabilitated now. They are fully saturated. Anyway, thank you.
You have explained nicely.
Yeah.
We have no questions.
I know. Thank you very much. Thank you, Gunendrika. Nice to hear your voice. Thank you. Thank you.
Thank you for accepting our invitation.
Anytime. I'm getting older now. My brain is also getting older. So whatever I can do, I'll be always there to help you. And Monica was telling me this morning that you all are going to get involved in managing medical patients. So my best wishes, my blessings to you. And it's a great thing. I think it's very meritorious that you are getting involved in that. So thank you very much.
And if you interesting presentation,
you are most welcome.
At the outset, I introduced as the lecture or talk of the year. So thank you very much for not only for this presentation and for the great service done and been continuing to improve not only the field of rheumatology, the medical rehabilitation field.
Thank you very much. Thank you.
Thank you very much, sir.
And also, Monica, if you think an old man like me can be of any help to your teaching process, to take a small class, I'm always available. As you know, that is, I get drunk by teaching people. That's the way I get drunk, by teaching people.
Okay, so, thank you very much, sir.
Thank you very much, Monica. Take care. Thank you. Thank you. Bye.
Thank you. Bye. Our next presenter is Dr. Narani Aravinthan, consultant in rheumatology and rehabilitation from Teaching Hospital Jaffna. Dr. Narani will be speaking on the diversity of clinical presentation of Takayasu Arteritis patients at Teaching Hospital Jaffna. Dr. Narani is an enthusiastic young rheumatologist from Jaffna. Over to you, Narani.
Good afternoon to you all. First, thank you very much, madam, for your kind introduction. First of all, I would like to thank the association for giving this opportunity. Today, I would like to present the diversity in clinical presentation of Takayasu Arteritis at Teaching Hospital Jaffna. Altogether, I have 13 patients at my clinic. Their presentation by
Can't hear. Narani can't hear. Okay. Are you okay? Okay, Narani? Okay, Narani, now we can see the screen. You can continue. Hello, Narani?
Yeah. Can you hear me, madam?
Yes, yes, we can hear.
So the case one, she is 35-year-old female. She was diagnosed as seronegative arthritis 2 years back. And she had the features of inflammatory arthritis and constitutional symptoms. While on treatment, she presented with shortness of breath and unexplained tachycardia. We rule out the possibilities of atypical pneumonia and acute coronary syndrome. And our great concern was about pulmonary embolism. She was arranged with CT pulmonary arteriogram. There were no features of pulmonary embolism, but changes were compatible with pulmonary arthritis. For that, she was arranged with CT angiogram and diagnosed with type 2A Takayasu Arteritis, and she was started with steroid and cyclophosphamide. The question is, why we missed during the initial presentation? The second case, 29-year-old female, she was referred from ENT surgeon for neck pain with a question of cervical radiculopathy. And when I did the examination, her neck movements were slightly reduced, especially on right side flexion. Otherwise, neurological examination of upper limb was normal, including swelling test and shoulder abduction sign. However, I found there was marked tenderness over the right carotid area with suggestive carotinia, which raised the suspicion of Takayasu arteritis. When I questioned the patient, she had right arm claudication and there was weak radial pulse on right side. And CT arteriogram was arranged for that and diagnosed with type 1 Takayasu arteritis. And she was started with the treatment. The question is that the carotinia is a common feature of Takayasu arteritis.
Can't hear, Narani. We can't hear. Narani, we can't hear. You have to unmute.
Sorry for the interruption. The third case, previously healthy 32-year-old female, she was brought to the hospital with a history of generalized tonic-clonic seizure with loss of consciousness of 10 minutes. Neurological examination revealed there were no abnormalities, including pancreas. However, the cardiovascular system examination revealed some abnormalities. There was weak radial pulse on the right side, and we noticed the blood pressure difference. And bilateral carotid, vertebral, and renal bruise were there. And for that, she was arranged with CT autogram, diagnosed with type 5 Takayasu arteritis. And she was started with steroid and cyclophosphamide. Case 4, 33-year-old male. He was brought to hospital with a history of abdominal pain, diarrhea with low-grade fever for 1 week duration. And he had similar illness in the past. Initially, we thought as gastroenteritis. However, the board registrar, she was very keen in detecting signs and she noticed there was radial pulse weak on right side. And also she noticed the blood pressure difference. And which raised the suspicion of polyarthritis nodosa because of male patient, and Takayasu arteritis. And for that, the patient was arranged with ultrasound abdomen, which was normal. And CT mesenteric angiogram and aortogram were arranged. The changes were compatible with arthritis, involved right subclavian artery, mesenteric artery, and the patient was started with steroid and cyclophosphamide. The case 5, 35-year-old female, she presented to the cardiology board with ischemic type chest pain. The diagnosis was made as acute coronary syndrome, and for that the patient was arranged with angiogram, showed the features of triple vessel disease, and patient underwent for the bypass surgery. Because of young female with triple vessel disease and high ESR, the patient was thoroughly investigated to find out the etiology. And we noticed the radial pulse beat on left side, and also we noticed blood pressure difference. For that, the patient was arranged with CT arteriogram, and changes were compatible with arthritis, involved ascending aorta, bilateral subclavian artery, and diagnosed with type 2 Takayasu arteritis. Screening was done to rule out the possibilities of tuberculosis, HIV, and syphilis, all were negative. So by looking at these cases, these 5 cases, the case 1 and 2 emphasize the importance of evaluating symptoms and signs rather than getting the diagnosis made by the referring clinician. Third, fourth, and fifth cases, even though they have the typical feature of Takayasu arteritis, you can see their manifestation involved in various systems. Therefore, it is very important for the correct diagnosis should be made in a correct person at correct time. So what is Takayasu arteritis? Basically, the vasculitis can be classified into 3 types: large vessel vasculitis, medium vessel vasculitis, and small vessel vasculitis. Takayasu arteritis and giant cell arteritis are classified into large vessel vasculitis. It is an inflammatory stenotic disease of medium and large arteries. It is defined as granulomatous inflammation of the aorta and its major branches. It leads to wall thickening, fibrosis, stenosis, and thrombus formation, which can lead to organ ischemia. In case of more acute inflammation, can destroy the arterial media and can lead to aneurysm formation. So what's the correlation between this person and Takayasu arteritis? He is Professor Takayasu, the professor of ophthalmology. He is the one first diagnosed Takayasu arteritis in 1905 when 21-year-old female presented with abnormal fundal changes and absent radial pulse. So what about the incidence and prevalence of disease? It is most commonly seen in South Asia, Southeast Asia, and Mexico. The annual incidence is about 1.2 to 2.6%. So what about the Sri Lankan scenario? Currently, we don't have any data on prevalence and incidence. However, there have been few case reports published by rheumatologists. Among these, one of the case reports regarding epileptic seizure and unusual presentation of Takayasu arteritis was published from TH Hospital, Jaffna. So if we look at the epidemiology, it is a disease of young female, mainly of the 2nd and 3rd decades. We also can find children with Takayasu arteritis. The mean age differs from place to place. So at my clinic, the mean age is about 32 years. And also the female-male ratio differs from place to place. At my clinic, it is about 11:2. And also site of lesion differs from place to place. At my clinic, the common site was arch of aorta, combined with ascending and abdominal aorta. So if we look at the etiology, the genetic factor plays a major role in the etiology. It determines the site of lesion. The second factor is autoimmunity. The immune reaction against elastin play a major role in the etiology. Infections like tuberculosis, streptococcal infections, spirochetes, and virus play a major role in the etiology. The case 6, 31-year-old female, she presented with right arm claudication, typical feature of Takayasu arthritis, and there was weak radial pulse on right side, and we noticed the blood pressure difference, and also there was a bruising in right subclavian artery. For that, she was arranged with arteriogram and showed the features of Takayasu arthritis involved arch, descending, and abdominal aorta. Unfortunately, she had more positive, which was about 14 millimeter. However, she didn't have any past history or contact history of tuberculosis. These were the questions we had during that time, whether it was due to TB arthritis, or TB may be the triggering factor for Takayasu arthritis, or Takayasu arthritis and incidental finding of positive marker. Anyhow, active tuberculosis was excluded with the help of imaging and chest vision help, and she was started with methotrexate and steroid. So what's the correlation between tuberculosis and Takayasu arthritis? So there was a study done in Chinese population among around 1,105 patients were included in this study. Out of these patients, 109 had tuberculosis. Out of 109, 48% and 6% of patients, they developed tuberculosis before the onset of Takayasu arthritis. And 21% developed concurrently with Takayasu arthritis, and 22% developed after the onset of Takayasu arthritis. So you can see a certain number of patients develop tuberculosis before the onset of Takayasu arthritis. In case of TB aortitis, the common site of lesion is pulmonary artery. The cross reaction between tuberculosis and leash of protein play a major role in the pathology. So how can we differentiate TB aortitis from Takayasu arthritis? It is very, very difficult to differentiate both situations. However, TB aortitis, you can see, is actually aneurysm and non-obstructive lesions. And also the most common sites affected by TB aortitis are pulmonary artery, distal part of arch, and descending aorta. In case of Takayasu arthritis, the multiple lesions in different arterial areas are common. However, the confirmatory test is a biopsy where you can see cascading granuloma in case of TB aortitis and non-cascading granuloma in case of Takayasu arthritis. So this chart shows the frequency of arteriographic abnormalities and potential clinical manifestation of arterial involvement. You can see the subclavian artery is most commonly affected. They can present with arm claudication and Raynaud's syndrome. My data. And also, I had some experience with other arterial involvement due to Takayasu arthritis. However, I never had any experience of vertebral or iliac artery involvement with Takayasu arthritis. So, according to my data, the coronary artery involvement is a little bit higher when we compare with the international data. The case 7, the 42-year-old female, she was referred by consultant neurologist with a history of left shoulder pain with high ESR and rheumatoid factor with a question of rheumatoid arthritis. When I tried to do the squeeze test to find out whether the patient is having any features of active sinusitis, I found unilateral grade 3 finger clubbing on the left hand, which raised the suspicion of coarctation of aorta because of asymmetrical clubbing. And when I examined the patient, her radial, ulnar, and rectal pulses were barely felt in the left arm. Blood pressure was not recordable in the left arm, and in the right, it was about 112/88. Then the patient was arranged with arteriogram and diagnosed with type 2B Takayasu arthritis, and she was started with steroid and mycophenolate. Even though the above chart doesn't mention about clubbing as one of the manifestation of Takayasu arthritis, which can happen in case of Takayasu arthritis. So what is the hypothesis behind that? It is by Dickens and Martin. According to their hypothesis, the severe arthritis that can produce stenosis and aneurysm, which can produce local hypoxia and can release some mediators. These mediators can increase the vascular permeability and number of vascular smooth muscle cells can be increased, which can cause digital clubbing. In case of early clubbing, can be reversed with treatment. So when and where you can suspect Takayasu arthritis, basically it evolves into 3 stages. The first phase is the pre-pulseless phase, and second phase is the pulseless phase, and third phase is the burnt out stage. So how to catch up the patient at pre-pulseless stage? It's very, very difficult to catch up at this point because of non-specific symptoms like arthralgia, arthritis, myalgia, constitutional symptoms. Therefore, that's why we missed the case 1 during the initial presentation. So therefore, what we can do, if we find any patient with non-specific symptoms with high inflammatory markers, we can closely follow up the patient. We can closely monitor the patient whether this phase evolves into pulseless phase. During the pulseless phase, the patient may have the typical feature of Takayasu arthritis. So whenever you get any referrals from cardiologist or physician with a history of claudication, carotidemia, hypertension, aortic regurgitation, myocardial infarction, Raynaud's phenomenon, young female, you need to consider Takayasu arthritis. So you have to check all the pulses, and you need to check for the pressure difference and check for the bruit. And also you can get some referrals from neurologist with a history of headache, visual disturbance, stroke, and transient ischemic attack and seizure. In a young female, you need to consider Takayasu arthritis. And also don't ignore if you get any referrals from dermatologists because they can present with pyoderma gangrenosum, erythema nodosum, and ulcerated nodule. Once a working diagnosis is made, it's very important to confirm the diagnosis with the help of diagnostic criteria. There are 3 types of diagnostic criteria. Among these, normally we use Acl criteria because of the flexibility, high sensitivity, and specificity. So the Acl criteria includes 6 criteria. Out of these, the 3 or more than 3 should be there to confirm the diagnosis. The sensitivity is about 90% and specificity is about 97%. So most of the time, the diagnosis of rheumatological condition is not black and white. Therefore, we need to do 3 sets of investigation to confirm the diagnosis, to find out the etiology and rule out other possibilities, and to find out the complication and the disease activity. For the confirmation, we can start from baseline investigation like inflammatory markers. ESR should be more than 50, CRP is elevated, and through the count, you can see the features of lipocytosis, thrombocytosis, and anemia. So what are the features you can see in the chest X-ray? You can see the aortic widening, thyroid prominence, and cardiomegaly. And also you can see notching of the ribs. In the echocardiogram, you can see the features of aortitis syndrome, enlarged or narrowed aorta, dilated left ventricle or left atrium, thickened interventricular septum, and left ventricular posterior wall thickened, aortic root dilatation, and aortic regurgitation. The X-ray abdomen will show the features of aortic calcification. When we go to the imaging, the conventional angiography is the gold standard method for the diagnosis. It reveals focused, smooth, symmetrical narrowing of the aorta. And also you can see multiple branch vessel stenosis or occlusion. Stenosis is the most common finding. However, you can see arterial dilatation and fusion of aneurysm. It will help us to differentiate fibromuscular dysplasia. And also which will help to type the Takayasu arthritis. There are 5 types of Takayasu arthritis. The type 1 involves arch of aorta, type 2 ascending and arch, type 2B ascending arch and descending, type 3 descending and abdominal aorta, type 4 abdominal, and type 5 anti-aorta involvement. The second option for the imaging is MRI. It reveals the anatomical features such as mural thickening, luminal changes, and aneurysm formation. The main benefit of using this method is lack of radiation. And also, the disease activity and response to treatment can be assessed by this method. The other option for the imaging is the high resolution Doppler ultrasound, especially for the common carotid and vertebral arteries. It is tenfold more sensitive than MRI. It will help us to differentiate the active disease from inactive disease by measuring the carotid wall thickness and vessel diameter. The other option for the imaging is PET scan, especially for the large vessels. And the major advantage of using this method is even during the pre-pulsus phase, we can diagnose Takayasu arteritis. Tissue biopsy, it is a confirmatory test for the Takayasu arteritis. However, it plays little role or no role. You can see the continuous physiognometric changes, and in latter part of the disease, you can see sclerotic changes. Suggestion for the practical approach of the diagnosis of Takayasu arteritis and selection of the imaging methods. If you have facilities for the CT and MRI for luminography, it would be better than the CT angiography because of lack of radiation. If you have the facilities for the MRI, it is really great rather than CT because of lack of radiation. And also, if you want to evaluate the heart, MRI would be the good option. And for the extracranial carotid arteries, ultrasound would be excellent. In case of pyrexia or unknown origin, the best option would be PET scan. We have to do some investigation to rule out other possibilities, and to find out the etiology, we need to do some investigation. So we have to do rheumatoid factor, ANA, and class studies, antiphospholipid antibodies, and screening needs to be done to rule out the possibilities of tuberculosis, syphilis, and also we need to do ASOT. For the complication, depends on the organ complication, we can do the investigations. Usually, the fundus, you can see two types of complication. One is a hypertensive retinopathy, where you can see the features of exudates and hemorrhages. In case of ischemic retinopathy, you can see cherry red spot appearance. So if we look at the management of Takayasu arteritis, why the management of Takayasu arteritis is not easy? Because the early diagnosis, especially the first phase, the pre-pulsus phase, diagnosis is difficult. And lack of standard and reliable parameters reflecting the disease activity. And third thing is the low level of evidence. So when we look at the supporting measures, we need to educate the patient regarding proper diet, and also education should be given for exercise, and blood pressure should be checked. If you find any patient with resistant hypertension, it's very important to rule out the possibility of renovascular hypertension. So what about the antiplatelet treatment? There are controversial ideas regarding antiplatelet treatment for Takayasu arteritis. However, the EULA and BSR do not recommend of giving antiplatelet or anticoagulant therapy for Takayasu arteritis patient unless the patient does have any features of coronary artery disease or cerebrovascular accident. Likewise, the giving of routine lipid-lowering drug is not recommended by BSR and EULA. So what about immune suppression? We need to know the efficacy of the steroid, efficacy of additional immune suppressant, and biological agents. So what are the goals of immune suppressant? The goals are induction of remission, maintenance of remission, prevent the progression of the disease, attain the regression of the disease. You know, most of the diseases, the first line treatment is steroid. However, we need to know the starting dose and how to tailor the steroid. The starting dose for the Takayasu arteritis is 40 to 60 milligram per day. There has been no evidence for starting dose above 60 milligram. In case of more localized diseases, the patient may be given with 25 to 30 milligram per day steroid. Once the symptoms control, the dose can be reduced slowly to 15 to 20 milligram per day after second or third month. Even after second or third month, the dose should be reduced slowly to 10 milligram or less than 10 milligram after 1 year. When we give long-term steroid, we need to think about bone protection treatment. Also, we need to consider the side effects of steroid. According to studies, 60 to 80% of Takayasu arteritis patients who were given with steroid developed relapse, And also they develop new vascular lesion. Therefore, the recommendation is to start disease-modifying drug, that is a non-biologic disease-modifying drug, as early as possible. So what are the drugs we can start? Methotrexate, mycophenolate, leflunomide, and azathioprine. The choice mainly depends on the comorbid situation and contraindication. Even though there have been few studies to assess the efficacy of the drug individually, it is hard to see any study done to compare which is superior than inferior. If the patient can't tolerate the first choice, the first choice can be swapped to the second choice. Once the remission achieved, then the disease-modifying drugs can be reduced slowly after 1 year of remission. If the above drugs have failed or these drugs haven't been tolerated, then we can think about cyclophosphamide. In case of relapse, we will see later, we can consider tocilizumab and T1 factor inhibitors. The main goal of treatment target is sustained remission. So one case I mentioned about the Takayasu Arteritis and positive mark. So there are three categories. One is the latent tuberculosis with active TB. So the priority should be given for the Takayasu Arteritis, and treatment should be started for Takayasu Arteritis with or without hemoprophylaxis. In case of active tuberculosis and inactive Takayasu Arteritis, the priority should be given for tuberculosis and anti-TB drugs should be started. The third category is the active TB and active Takayasu Arteritis. So it is very difficult and complicated situation. Who should look after the patient, his physician or the rheumatologist? I hope look after by both would be the good option. Even though the priority should be given for tuberculosis, we need to consider steroid at the same time. However, the question is when we are going to start the steroid. It's mainly we need to discuss with the chest patient in view of the active status of the tuberculosis. After that, we could think about starting steroid. Azathioprine is not safe drug, and cyclophosphamide is not safe during active TB because the cyclophosphamide and rifampicin combination, which can increase the toxic metabolite of cyclophosphamide. Methotrexate would be the good option. In case of biologics, rituximab would be the good option. The case 5, she was diagnosed with triple vessel disease due to Takayasu Arteritis, had undergone for bypass surgery in 2016, and she had been given with steroid and 6 passes of cyclophosphamide and maintained with mycophenolate. While on MFF, she presented with ischemic type chest pain to the ward in December 2020. The pressure was about 160, and other examination findings were similar as she had before. ECG, the features of ST elevation MI, troponin was positive, inflammatory markers were high. Repeat angiogram showed the features of 90% stenosis of left main coronary artery. And she was managed as acute coronary syndrome by cardiology team. So from our point of view, how the patient can be managed. It show the features of relapse. The relapse can be divided into major and minor relapse. For that, we need to know about the disease activity, how to assess the disease activity, why is it important, is it an easy one or problematic. Usually, during the follow-up, we need to go through the following 4 things. So whenever the patient develops new onset of worsening of 2 or more of these things, indicates the high disease activity. However, there are few drawbacks by using this system. Therefore, the gold standard method to assess the disease activity is ACLAS 2010. There are 44 items in this system. Out of 44, 33 are related to cardiovascular system. And each item is given with different marks. There are 7 items mainly related to cardiovascular system given with 2 marks, and other items given with 1 mark. New manifestation during last 3 months are to be recorded, and also that we need to put the marks for each item, and ultimately we have to calculate the total marks. For that, we need to give marks for the inflammatory markers and physician global scale. Ultimately, after putting the total marks, we can guess whether disease is in active stage or the inactive stage. There are few circulatory markers to assess the disease activity. Those are matrix metalloproteinase, pentraxin 3, and interleukin 8. In case of relapse, the major relapse, the symptoms and signs suggestive of progressive vascular lesion or new vascular lesion indicates the major relapse. In such situation, the steroid dose should be increased to higher dose, and also the patient should be added with tocilizumab or TNF blockers. In case of minor relapse, the steroid dose should be increased to the last effective dose. So this diagram shows how to manage Takayasu arteritis. So once a diagnosis is made, we need to start high dose of steroid. With that, we have to start the disease modifying drugs. Once symptoms control, then we can tail off the steroids slowly to 15 to 20 milligram after second or third month. Even after second or third month, the dose of steroid should be reduced slowly to maintain at least 10 milligram or less than 10 milligram after 1 year. So once the remission achieved, the disease modifying drugs can be reduced after 1 year of remission. In case of the remission is not achieved, it can be major relapse or minor relapse. In case of major relapse, the dose should be increased to higher dose. With that, the patient should be added with tocilizumab and TNF blockers. In case of minor relapse, the dose of steroid should be increased to the last effective dose. So when I went through some case report, there were two interesting case reports regarding TNF blockers. One patient with seropositive rheumatoid arthritis, the patient was given with adalimumab, and other patient is seronegative spondyloarthropathy, the patient was given with golimumab, developed Takayasu arteritis after the TNF blockers. So when we give TNF blockers for Takayasu arteritis, we need to keep things in our mind. Sometimes we can come across some patient without any features of activities, having persistent high ESR and C-reactive protein. If you find any patient like that, first we need to rule out the possibilities of infection. Once the infection is excluded, we need to repeat the inflammatory marker. If these inflammatory markers are persistently high, if we cannot find out the reason for the high inflammatory marker, the patient should undergo for imaging to find out whether the patient developed any vascular lesion. The case 9, 21-year-old university student, she was referred from medical ward with a history of pyrexia of unknown origin, headache and pulsatile lump on right side of the neck with a high inflammatory marker with a question of connective tissue disease. There were no history of arthralgia, arthritis, chest pain, palpitation or shortness of breath. There was no history of abdominal pain, no features suggestive of connective tissue disease. Cervical lymph node was enlarged. Cardiovascular system revealed the weak pulse on left side radial artery, and also bruit was detected in right subclavian and both carotids. Echo was arranged for that, and also that was normal. And she was arranged with RTA Doppler and CT angiogram, which show the features of dilatation of the aorta from aortic root to origin of renal arteries. And also left common carotid artery was thickened. And these arteriograms show the features of multiple segmental aneurysm. The largest one was in brachiocephalic trunk. It was about 2.5 centimeters. Screening was done to rule out the possibilities of tuberculosis, HIV and syphilis, all were negative. We did the vascular surgeon referral in view of the surgical intervention for the aneurysm. However, he refused to do the surgery in this patient. He will see why later. She was started with steroid and cyclophosphamide and maintained with mycophenolate. So if we look at the aneurysm in Takayasu arteritis, it indicates poor prognosis. However, the rate of growth and risk of rupture is less when we compare with the atherosclerotic aneurysm. According to studies, occlusive disease is more prevalent in United States and Europe. And aneurysms are common in Japan, India, Thailand, Mexico, and Africa. High frequency seen over the age of 40 years and is most commonly seen within ascending aorta. So what factors decide upon surgery of aneurysm? The first thing is the diameter. In case of abdominal thoracic aortic aneurysm, it should be more than 5 centimeters. And also the morphology, the propensity for dilatation of the lesion determine the time of surgery. However, young patients, as they have long life expectancy, the chance of getting rupture during this period might be quite significant. Therefore, they should undergo surgery a little bit earlier than usual. Even though the new techniques helps to do the surgery of aortic aneurysm involving thoracic and abdominal aorta, the surgical surgeries doing for the aneurysm in subclavian artery and carotid arteries are difficult because of the complications like stroke. That's why our patient was refused by vascular surgeon to do the surgery. The above patient, a few months back, while on MFM, she presented with shortness of breath. We ruled out the possibilities of pulmonary embolism, pneumonia, including COVID pneumonia, and acute coronary syndrome. Echo was repeated, showed the features of grade 3 of aortic regurgitation. And CT angiogram was arranged, showed the features of aortic root dilatation, which was about 4.1, and the brachiocephalic trunk dilatation was about 4.1. The previous one was about 2.5. So these features suggested the progression of the disease. Therefore, she was started with high-dose steroid and she was given with tocilizumab monthly infusion. We did the cardiology and cardiothoracic referral. Cardiothoracic surgeon decided to do the surgery for the aortic regurgitation. So what are the indications for surgery in case of Takayasu arteritis? Renovascular stenosis causing hypertension, coronary artery stenosis leading to myocardial ischemia, extremity claudication induced by routine activity, cerebral ischemia and critical stenosis of 3 or more cerebral vessels, aortic regurgitation, thoracic or abdominal aneurysm larger than 5 cm in diameter, and severe coarctation of the aorta. These are the indications for the surgery. So there are 2 methods of surgical intervention. One is the endovascular intervention, other one is the surgery. It mainly depends on the size of lesion. We need to know something about the pregnancy and Takayasu arteritis. If the patient not treated, so what are the complications that can happen? Especially cardiovascular complication. Not only the mother, even the fetus can be affected. The peak incidence is in 2nd or 3rd trimester. The mother, she can develop pregnancy-induced hypertension a little bit earlier than usual, and also she can develop multiple organ dysfunction, acute retinopathy, aneurysm, and aortic regurgitation. The fetus can develop growth retardation, abortion, death, and death. Therefore, before going for the pregnancy, the disease should be in inactive stage. So how can we manage the pregnancy with Takayasu arteritis? It is a team approach. Team should include obstetrician, rheumatologist, cardiologist, and neurologist. The fetus should be monitored, and blood pressure should be monitored in both upper limbs and lower limbs, especially the patients with severe renovascular hypertension, cardiac and pulmonary hypertension. And also, we need to monitor the renal function, cardiac status should be monitored, and we need to do the screening for preeclampsia. If you look at the mode of delivery, the vaginal delivery would be preferable. In case of hypertension, delivery should be abbreviated by the use of outlet forceps. In case of stage 2B and 3, the better option would be cesarean section. Thank you for listening me. Any question you can ask.
There is one question in the chat box from Gunendrika. So in first case, what was the indication to do aortic angiogram after the normal CPT?
So because that radiology suggested if we do the CT pulmonary angiogram, the intra-aorta cannot be visualized clearly. That's why radiology, she is the one suggested to do the CT aortogram to see the complete, to see the changes of intra-aorta.
Thank you, Narani.
Other thing is, we have noticed that several patients who had babies without complication, even one patient whom initially the cardiologists have asked not to have a baby, but about 3-4 patients, even with severe hypertension, they continued the pregnancy without complications. That I have noted. Actually, it's better if everybody can collect this data like this and have a database for Takayasu Arteritis. Narani, we are going to have a registry. Yeah, we will.
Don't get the data. Yeah.
Yes. Okay. Are there any questions? Other things, another thing that we have noted, so we are tailing off steroids more rapidly, I think too rapidly, even at the 1 year, according to EULA recommendation that they say at least 10 milligrams should be continued even at the end of 1 year life. So yes, we know, like in rheumatoid arthritis and other diseases, we can't tail off steroids rapidly in Takayasu, isn't it, Narani?
Yeah, exactly.
So, in the absence of questions, I would like to thank Dr. Narani Aravinthan for this very interesting presentation on behalf of College of Specialists in Rheumatology and Rehabilitation. Thank you very much, Narani.
Thank you.
Our next presenter is Dr. Amanda Embuldeniya, Senior Registrar in Rheumatology and Rehabilitation from Rehabilitation and Rheumatology and Rehabilitation Hospital, Ragama. We'll talk to you on young male with SLE. Over to you, Amanda.
Thank you, madam, and good afternoon to you all. Today, I'm going to discuss about a young male who presented to us a couple of months ago with SLE, where we had to face a lot of diagnostic and management difficulties. So our patient was Mr. S, a 17-year-old male from Karavanalla. He presented to us with prolonged febrile illness lasting for 3 weeks duration. And this febrile illness was associated with mild epigastric pain and also severe reflux symptoms. And he had noticed puffiness of his face in the mornings with bilateral ankle swelling, but he denied any episodes of hematuria or passage of prothurine, and his urine output has been normal throughout this period. But he gave a history of 2 episodes of painless oral ulcers in the past associated with significant alopecia. And our patient had lost his appetite and there was a loss of weight as well, which was not measured objectively. But patient denied any past or contact history to pulmonary tuberculosis. And there was an episode of generalized tonic-clonic seizure while he was in the medical ward, which was witnessed by the hospital staff, but there was no prior history of epilepsy. So his past history was significant for a hospital admission about 9 months ago, where he presented to his local hospital with acute severe abdominal pain associated with deep jaundice. And there he has been evaluated and transferred to the tertiary medical care hospital as well. And he has been diagnosed as acute on chronic pancreatitis with evidence of hemorrhagic pancreatitis complicated with biliary sepsis. And the same hospital admission was complicated with acute kidney injury, managed as severe bilirubin nephropathy, and because he was having severe hyperbilirubinemia, and he has been offered a couple cycle of hemodialysis as well. And there was history of pancytopenia at that time, complicated with neutropenic sepsis, but upon discharge, both his renal functions as well as his cell counts have improved. So our patient was a regular user of cannabis, and he admitted that he was using methamphetamine also occasionally, and he abused alcohol, and there was a 4-pack-year history of smoking as well, but he denied IV drug abuse or high-risk sexual behaviors in the past. So he was a school dropout with poor literacy skills, and he was living with his mother with poor socioeconomic background and inadequate family support. And he demonstrated poor coping skills while he was in the hospital. And he was employed as a manual laborer before this admission. So on examination, our patient was emaciated. His BMI was 14.8, and he was pale but anicteric. There was no lymphadenopathy, active synovitis, or skin rashes suggestive of a connective tissue disorder, but there was evidence of healed oral mucosal ulcers, and he had mild bilateral pitting ankle edema as well. And we also noticed that there was lack of secondary sexual characteristics. So his cardiovascular system examination was normal with a normal blood pressure, and he had clear lung fields. And abdominal examination was significant for a bilateral flank dullness. And nervous system examination revealed sensory impairment in bilateral lower limb, suggestive of a sensory predominant peripheral neuropathy. And on mental state examination, there was evidence of mild to moderate depression, and patient came up with a past history of suicidal attempt as well. However, he denied any active suicidal ideation or psychotic symptoms. So after history and examination, the differential diagnosis we thought about this patient's presentation were whether this was a presentation of retroviral infection since patient had a high-risk background, or whether these are related to the underlying chronic substance misuse, or whether this is a presentation of a connective tissue disorder like systemic lupus erythematosus. So we went ahead with basic investigations, which revealed normochromic normocytic anemia with marginally low platelet count, and blood picture revealed evidence of mixed deficiency anemia without any evidence of hemolysis, and his DAT profile and coagulation studies were within normal limits, and his urine albumin was 4+, and UFR revealed the presence of RBC, but casts and dysmorphic RBC were negative. And urine protein quantification revealed a nephrotic range proteinuria with normal renal functions. And we noticed that his ESR was persistently elevated, but his CRP was within the normal limit. So he also had elevated liver enzymes with low serum albumin and altered albumin to globulin ratio. However, his bilirubin, alkaline phosphatase, and serum amylase levels were normal during this admission. So his chest X-ray did not reveal any evidence of previous pulmonary tuberculosis or pleural effusions, and we also excluded the possible latent and active tuberculosis. And his transthoracic echocardiogram was again normal, and retroviral screening, syphilitic, and viral hepatitic screenings were also negative. So the new problems identified after the basic investigations were this mixed deficiency anemia, the presence of nephrotic syndrome, and the liver impairment. So then we went ahead with second line investigations, and his ANA in immunofluorescence was positive in 1 in 320 with a cytoplasmic fine speckled pattern. And his dsDNA was also positive with low C3 and C4 levels. And we went ahead with renal biopsy to assess his renal impairment, which revealed evidence of diffuse proliferative lupus nephritis with both active and chronic lesions suggestive of class 4 lupus nephritis. So at that point, we could classify this patient's presentation as SLE according to 2019 ACR criteria. However, the other complications like mixed deficiency anemia, hepatitis, chronic calcific pancreatitis, peripheral neuropathy, and depression, we were not very sure whether these are caused by SLE per se, or there's a contribution of the underlying substance misuse history. So later on, the other investigations were carefully interpreted in the clinical context with the relevant help of the relevant subspecialties. So his anemia was further evaluated with a bone marrow biopsy, which revealed suppression of all 3 cell lines with evidence of megaloblastic and other toxic changes. So the impression made was possible drug-induced bone marrow hypoplasia. And then we went ahead with ultrasound imaging of the abdomen, which confirmed the previous history of chronic calcific pancreatitis with the presence of pancreatic pseudocyst. And also there were changes suggestive of chronic kidney and liver disease as well. So the contrast enhanced CT abdomen further confirmed the presence of pancreatitis and pancreatic pseudocyst. However, ERCP did not reveal any evidence suggestive of bile duct obstruction. So his liver enzyme elevation was further evaluated with the liver biopsy. So there was evidence of acute hepatic process with cholestasis. And the possible etiologies were considered as drugs or toxins, because the typical changes which are seen in autoimmune or lupus hepatitis were not seen in this biopsy specimen. And following the episode of generalized tonic-clonic seizure, patient underwent a MRI brain also, which revealed early cerebral atrophy, but his MR angiogram and venogram were both negative, as well as his EEG. And the nerve conduction studies confirmed the presence of axonal type sensory neuropathy, which was probably due to the underlying substance misuse. And we referred the patient to the psychiatry team as well for his depression and substance misuse. And they started the patient on treatment. And the possible cause for his delayed secondary sexual characteristics were considered as malnutrition and underlying chronic illness causing hypothalamic suppression. And currently patient is under evaluation for that, and he's recovering from that. And with regard to the management of this patient, so after investigation, we started him on oral prednisolone 1 mg per kg dose with hydroxychloroquine. And after the discussion with the nephrology team, we started him on mycophenolate mofetil. The dose was titrated up to a bed-based maximum dosage. Then his anemia was corrected with iron and vitamin supplementation. And the meal-induced pain and chronic pancreatitis was treated with pancreatine. Then after discussion with the psychiatry team, because most of the antidepressants could exacerbate another episode of pancreatitis, we started him on amitriptyline. And for the malnutrition part, we started him on nutrition supplements as well. And he was given vocational rehabilitation, and literacy skills were also improved by the occupational therapist while he was receiving in-ward treatment. So during this prolonged period of treatment, patient developed some complications such as metabolic myopathy and grade 2 fatty liver with high doses of steroid. However, these complications were improved with tailing off of the steroid dose. And these are the response for the treatment after the 5 months of prolonged hospital stay. His BMI improved to 16.4 on discharge, and his anemia also improved. And he had a complete renal response to the steroid treatment, and his serum albumin level also improved. And currently patient has 7 months of complete abstinence. So I'd like to talk a little about SLE in males, whether it is an overlooked diagnosis. So how common is SLE in males? So it is one of the most overrepresented diseases in women, with a female to male ratio of being 9:1 or 10:1. But the prepubertal and post-menopausal ratios are much lower than this. And 4 to 22% of SLE patients in reported series are found to be males. So why SLE is not so common in males? So there are few contributory factors proposed in previous studies as well as in literature. However, the interaction and the degree of contribution of these factors to the development of an autoimmune disorder is still poorly understood. So some of these proposed factors are the intrinsic sex differences of the immune system, and the difference of sex hormones, chromosomes, and differences in genes, and sex-dependent environmental factors, as well as the effect of the gut microbiome. So with regard to the presentation of SLE in males, so this sex difference in disease susceptibility is also resonate at the clinical level, and male sex has been associated with a more severe form of a disease in terms of clinical manifestations as well as the prognosis. And also the distinctive serological abnormalities have been found as more commonly seen in male patients. So the delay in diagnosis and poor health-seeking behavior and poor treatment compliance in men have been proposed to account for this poorer prognosis in males. And as we all know, the women with SLE are significantly more affected by cutaneous manifestations, whereas the skin manifestations are much more less common in male populations. But the male people present with more severe spectrum of organ manifestations. So they have overall increased organ damage as well as more frequent cardiovascular complications. So also the frequency of serositis is also increased in males, and this is particularly the increase in pleuritis, but not the pericarditis. And some studies have published, and they have proposed that there's a particular genetic mutation which is causing this predisposition to cause pleuritis more commonly in males. And estrogen also may play a crucial role in skin manifestations and flares in SLE. Therefore, the male population is not more frequently affected by this skin manifestations. So this is one of the studies published so far with the largest male SLE population at that point. So they have demonstrated that skin manifestations like male rash and photosensitivity are statistically less common in male population, whereas in serositis and renal disorders are more common in male patients. So as you can see in this systematic review, they have found out that the musculoskeletal disease, the skin disease as we discussed earlier, and Raynaud's phenomenon are less common in male population, whereas the end organ damage like neuropsychiatric disease, renal manifestations, cardiovascular disease, these are more common in male patients. And also certain lab abnormalities like positive lupus anticoagulant, the direct Coombs test, and positive low C3 and C4 levels are also more commonly seen in male population. So few facts about renal manifestations in male SLE. The differences in pathology of nephritis in males versus females have not yet fully understood. However, male gender is identified as a risk factor for renal failure in some studies. So high prevalence of renal disease is seen in male, and they have a poorer renal outcome and also poor survival rate because of the high prevalence of end-stage kidney disease. So class 4 lupus nephritis, which is the diffuse proliferative nephritis, is classified as the main or the predominant histopathological finding in male populations. And this is seen in both adult and pediatric SLE populations. So there are no proposed molecular mechanisms to explain this male propensity to present with renal manifestations. However, more immunological disturbances have been described in some cohorts. So whether there's an enhanced humoral response in males could exacerbate the inflammation occurring in renal tissue, contributing this progression to end-stage renal disease. We don't know about that so far. So a few facts about pediatric lupus. The gender difference in numbers of patients is much reduced in pediatric population. The ratio is 3:1, and the children have often an aggressive clinical course with more frequent renal involvement as compared to the adult population. So why should we know about this male sex and their presentation? Because male sex is associated with a more severe form of SLE, And men with SLE present more frequently with renal involvement, and they have a higher risk of progression to end-stage kidney disease, hence higher mortality. And the identification of this difference in SLE manifestation is crucial to raise the awareness of a more severe disease course in male patients. So whether this sex difference is affecting the drug activity or a specific therapy should be developed based on the gender of the affected patient, there are no published researches so far. So a tailored treatment for males and females might So that brings to the end of my presentation. I'd like to thank my supervisor, Dr. Amanda Embuldeniya, the consultant rheumatologist at RRH, and also the medical team at Professorial Medical Unit Ragama, and all the consultants in subspecialties and their team who are involved in managing this patient. And these are my references. Thank you.
Okay, thank you, Amanda, for the interesting presentation. So as there is time, so are there any questions? So in the absence of questions, so I would like to thank again Amanda for this very interesting presentation on behalf of the college. So our next meeting will be in first Friday of September. Thank you very much for participation.